Welcome back to the Nematode Lectures. This recording will cover the two hookworms and also Strongyloides. So there are two hookworms we will be talking about, two different genus and species. The first one is Nematoes americanus, also known as the New World hookworm. The second one is Ancylostoma duodenale, or duodenale, however you want to say it, also known as the Old World hookworm. So as they sound, these two were named for their geographical distribution. So the New World hookworm was usually historically more isolated in North and South and Central America, and the Old World hookworm was seen more in Africa, Asia, and Europe. But today, with all the travel we have, they're not really just isolated in those places anymore, although the names still stick with each genus and species. It is estimated that 25% of the world is infected with hookworms. 1/4 of the world's population is infected with hookworms. So that's pretty alarming. What's helpful here is that the eggs of both of these species look identical. And in fact, you can go ahead and add a little note in your notes right now that Strongyloides stercoralis eggs are also indistinguishable from these two. So what that means is we're going to see one egg form, and really just blindly looking at it, you don't know if it's Nematoes americanus, Ancylostoma duodenale, or Strongyloides stercoralis. It could be any of those three parasites. So as this sounds like, they have hooks on them, or teeth, or cutting plates, and they can attach to the mucosa of the small intestines, and they actually ingest blood. So these guys are blood suckers. So speaking of that, this is one of the ways we distinguish between the two hookworms. So the New World hookworm has cutting plates in its buccal cavity or buccal capsule. The Old World hookworm has teeth in its buccal capsule. So that's what goes in the blanks up top, differentiating adult hookworms by their buccal capsules. Again, Nematoes americanus would have the cutting plates on the left, and you can see the much sharper teeth that the buccal capsule of Ancylostoma duodenale has. And a heavy infection of these worms can result in loss of up to 100 milliliters of blood per day. So in addition to drug therapy treatment, the patient might also need some iron supplements as well because of the loss of blood. Okay, starting off with their life cycles. So these two guys, both the hookworms, have the same life cycle. So let's imagine eggs are being shed in feces. Eggs need to reach the soil to have further development. So they're deposited in the soil, and in about 1 to 2 days, a larva hatches from the eggs. Now we have two new definition terms here. There's a rhabditiform larva and a filariform larva. So the first stage to come out of the egg is the rhabditiform larva. Now it's worth noting here that if constipation occurs, like the patient isn't shedding lots of feces, shedding feces regularly, rhabditiform larva may develop in the intestines, meaning the egg might hatch inside the patient and the rhabditiform larva could emerge there. But that's not as likely as eggs being shed and it developing in the soil. So after the rhabditiform larva stage comes the filariform larva. So rhabditiform larvae molt about a week later and mature into infective filariform larva. So as you can see here, this is the infective stage for the hookworms. It is having skin penetration of the falciform larva. So this most easily happens when people walk around barefoot and the falciform larvae are able to penetrate the bottom of the feet and penetrate the skin there. And if this happens multiple times, the patient may develop what's called ground itch, which is the site of the hookworm penetration. And this is an allergic reaction. It gets irritated and inflamed, and it's called ground itch, and it refers to where the falciform larva penetrated. Okay, here's your official definitions of these two new terms. So rhabditiform larva is the feeding but non-infective larval stage. This is the stage that hatches from the egg. And then falciform larva is the next stage. This is what's infective for us, the non-feeding but infective stage. The falciform larva can live up to 1 month in warm, moist soil. So we have a falciform larva that has penetrated skin. It enters the blood circulation, travels to the lungs, it gets coughed up, swallowed, it lands back into the intestines. It was never there in the first place. And the falciform larvae mature into adults, and adults lay eggs. This sounds a lot like what? The Ascaris lumbricoides life cycle. However, there's not a particular liver involvement like there was with Ascaris, but definitely lung, where you get that lung coughing, swallowing back into the GI tract. So here's a good picture. We can follow this real quick. We get falciform larva, skin penetration, usually at the bottom of the feet. It enters the bloodstream, lungs, up, over, into the stomach. The falciform larvae mature into adults. Adults mate, and eggs are shed. Eggs have to reach the soil where the rhabditiform larva hatches out of the egg. Rhabditiform matures into falciform. Falciform is infective. So I mentioned that ground itch, which is a dermatitis where the falciform larva entered the skin. We could also have symptoms when it's in the lung phase, definitely eosinophilia, and then non-specific intestinal symptoms. Now, the heavier infections, the patient will start to exhibit a hypochromic microcytic anemia due to that iron deficiency that's occurring. The diagnostic stage for both hookworms is eggs in feces. Remember, every single time you list a diagnostic stage, it needs to include the life cycle stage plus the specimen type. So eggs in feces or eggs in stool is the correct answer. Now, this may seem like it looks like not very characteristic, nothing to stand out about this egg. But once you start to look at hookworm eggs over and over, it will start to stand out to you. So it's got a thin shell, and the inside of it has these cleavages of the embryo. So you get these 4 to 8 little lobes that are occurring inside of the egg. And I always describe it as looking like a cloud. Now, in your first lab, this will be the hardest parasite for you to find in the slides because these are actual stool samples. The other slides you look at for the other nematodes, a lot of those are pure samples. So there's not any fecal debris. So hookworms should be the last one you look at, and it'll take you some time. But I want you to look for that thin shell. It's got to have a shell, and you need to use fine adjustment for it to stand out. You want to go up and down with fine adjustment. And then look for this cloud shape inside of it. And then once you see one and call the other call your other classmates over, when one student finds it, then you should be able to go back to your scope and know what you're looking for. Now, it's possible to see rhabditiform larvae in the feces if analysis is delayed, meaning we don't test the stool sample quick enough, and in the stool sample cup, rhabditiform larvae hatch out of the eggs that were in the stool. So if it sits out at room temp without a fixative, it's possible that this can happen. Or like I said, if the patient has constipation, then the eggs are hatching in vivo. So it's possible to see rhabditiform larvae, but when you are asked what is the diagnostic stage, your first answer is always eggs and feces. But we need to know about this possibility of seeing the rhabditiform larva because there is that possibility. So speaking of that, to jump ahead a little bit, the rhabditiform larva of hookworm closely resembles that of the rhabditiform larva of Strongyloides. So we have to memorize a couple facts to be able to differentiate these two. So the Strongyloides rhabditiform larva has a short buccal cavity and prominent genital primordium. A genital primordium is a clump of cells. It's like a precursor structure to their reproductive system. The rhabditiform larvae of hookworm have the opposite of those two things. They have long buccal cavities and small or maybe not even visible genital pores or genital primordiums. And I have a memory clue to share with you to help you remember this. I think it came from the LSU review book, and it's a cute picture. So Strongyloides, short and sexy. So the three S's go together. Strongyloides, short and sexy. Short, referring to its short buccal cavity, and sexy, referring to its prominent genital primordium. So I hope that helps you remember these facts. Another way to differentiate hookworm and Strongyloides is by their faleriform larva. So I will never show you a picture like you're seeing here of these larvae because it's too hard to tell, but you need to know the facts about them. So the hookworm faleriform larva has a pointed tail, and the Strongyloides stercoralis faleriform larva has a notched tail. Again, I know you can't tell this in the picture, but you need to know that fact. And then we just talked about how to differentiate hookworm and Strongyloides rhabditiform larvae by the buccal cavities and genital primordiums. A little bit of hookworm lagniappe. So I think it's important to note that animals can have hookworm. So there's a dog hookworm and a cat hookworm that can infect those animals. And normally the parasite just prefers those animals. But if a human were to get infected, we would be the accidental host, in which case we would be developing a zoonotic infection. So these are terms that were part of your definition words that you need to define. So in this zoonotic infection, if we were to accidentally get infected with these two animal hookworms, we could develop cutaneous larval migrans, which is the condition that you see here. So this is when these particular faleriform larvae, if the faleriform larva of these species penetrates us, the faleriform larva can't mature inside humans. We're not its normal host. So the faleriform larvae just migrate aimlessly. It's like they don't know what to do. They're just moving around, they can't mature, and they're just sort of stuck. and it's right subcutaneous, right under the skin. So what you see is actually the falciform larva just very, very surface. So that's called cutaneous larval migrans. And that's when we're accidental hosts for these two organisms. So that is the end of the hookworms. I know it seems like a lot, and I'm about to add some more stuff, dump some more facts on you, but just spending a little bit of time with it and saying it over and over again, making flashcards, these facts will start to sink in. Okay, Strongyloides stercoralis is the next parasite. This is also known as the threadworm. This guy can live in the small intestine, or it can have a free living cycle outside of the body. And do you remember this definition term? Remember, this is what we call a facultative parasite, where it can live apart from its host. What is the opposite of facultative? It is obligatory. So an obligatory parasite cannot live apart from its host. But this is our first example of a facultative one, where it can have a free living life cycle. So there's three forms of the life cycle actually that we'll talk about. Direct, which is very similar to the hookworms. Indirect, which is the free living phase, and then an autoinfection. So starting with the direct life cycle. Again, you'll notice this looks much like hookworm. We have falciform larval penetration of the skin, usually the bottom of the foot. It gets into the bloodstream, it goes to the lungs, it gets coughed up, swallowed, enters the intestines. Falciform larvae mature into adults. The adult female lays eggs. Now here, eggs hatch in the intestinal mucosa into rhabditiform larvae. So this is the normal course for Strongyloides. Remember, this could happen with hookworms, but it was only when the patient was constipated. This is the preferred course for Strongyloides. So the diagnostic stage for Strongyloides stercoralis, your first choice answer is rhabditiform larva in stool. It is not eggs in stool. It's rhabditiform larva in stool or feces. So then rhabditiform larvae reach soil and they mature into falciform larvae. And then falciform larvae are able to go penetrate the skin of somebody else. So this is the direct life cycle, much like hookworm. In the indirect life cycle, rhabditiform larvae may molt, transform, mature into free-living males and females. So in the soil, in the ground, the rhabditiform larva could skip the falciform larva stage and go directly to adults outside the body. And then they could mate, female can lay eggs, eggs could hatch into rhabditiform larvae, which mature into what goes here, falciform larva, and then falciform larva can go penetrate the skin of somebody else. So this is the free living cycle where an adult a rhabditiform larva can mature into an adult outside of a host. So this is unique for Strongyloides. And then the autoinfection. So when else did we talk about autoinfection? Do you remember? It was with the pinworm, where the same patient ingests the eggs that were shed in their perianal region. So sort of like that, where the patient is, infecting themselves over and over again. So this is when falciform larvae develop inside the intestines from the rhabditiform larva. So inside the patient's own body, inside the intestines, eggs hatch into rhabditiform larvae mature into falciform larvae, And then falciform larvae can go through the blood-lung cycle, and adults can mature from that. So it starts a life cycle within the same person. And this can be very devastating when the autoinfection occurs over and over again. Okay, I know this seems like a lot, and it is because strongyloides is a little bit more complicated, but it's very simple just by taking a minute with it. So actually it's showing our 3 life cycle phases: the autoinfection, the free living cycle, and the direct route. I'm going to start with the direct route and go backwards. So in the patient's intestines, we have eggs. Remember, the eggs are hatching, and rhabditiform larvae are getting passed in feces. So in the direct route, the rhabditiform larvae are in the soil. They develop into falciform larvae. Falciform larvae penetrate skin, bloodstream, lungs, stomach, intestines. Falciform larvae develop into adults. Adults lay eggs. Eggs hatch into rhabditiform, etc. In the free-living life cycle, we have rhabditiform larvae that were passed in feces, but here, the rhabditiform larvae can mature directly into adults. And we can get egg production outside the body, hatching into rhabditiform, maturing into falciform, and it can continue the same way. And then the third was that autoinfection, where actually rhabditiform larvae never leave the body. Rhabditiform larvae are maturing into falciform larvae in the intestines. The falciform larvae penetrate the intestinal wall, get into circulation, lung, GI, back to the intestines. Symptoms of strongyloides stercoralis. The abdominal pain can be pretty severe and sharp like an ulcer, but otherwise pretty nonspecific abdominal symptoms. However, it's the immunocompromised patients in which this could be fatal. So the disseminated strongyloidiasis is when that autoinfection occurs over and over again. And more than 80% of the fatalities are due to respiratory failure. It's due to the lung involvement that's occurring. And there's just falciform larvae everywhere in the body. Your diagnostic stage for strongyloides stercoralis, your first choice answer is rhabditiform larva in stool. And remember, how do we distinguish between strongyloides rhabditiform larva and hookworm rhabditiform larva? Strongyloides has the short buccal cavity and prominent genital primordium. How do we differentiate strongyloides falciform larva from hookworm falciform larva? Hookworm falciform larva have a pointed tail. Strongyloides falciform larvae have a notched tail. When would we see hookworm rhabditiform larvae in a stool sample? One of 2 reasons: the patient was constipated, or the sample sat too long and the rhabditiform larva hatched out of the eggs. But that's a secondary diagnostic stage. Your first choice answer for the diagnosis of hookworm is the eggs in feces. So along those same lines, to make things more complicated, if the patient has severe diarrhea, eggs may be found in the stool with a strongyloides infection. So if the eggs don't have time to hang out in the intestines, if there's constant passage of feces, watery passage, the eggs may be found in the stool and not the rhabditiform larva. And if we ever suspect that we have Strongyloides eggs, they are identical to hookworm eggs. So it's that thin shell and that interior that looks like a cloud. So that picture of that egg could be Ancylostoma duodenale, Necator americanus, or Strongyloides stercoralis. But that is your secondary diagnostic choice. It's your first choice is rhabdidiform larva in stool. Now, in a hyperinfection or large, exaggerated infection, falciform larva may be found in sputum. There's also a test we need to talk about called the Inero test. This is done to collect duodenal material without having to do intubation, which is fairly invasive to intubate someone. This is when a patient swallows a capsule that is attached to a piece of string. So this is easy to remember because this is called the string test, and Strongyloides is the threadworm. So those two things go hand in hand. The other end of the piece of string is taped to the patient's cheek or neck. And so they leave this piece of string with this capsule on the end. They leave this in the patient for like 4 hours. And then they pull up the piece of string that has the gelatin on the end, and the gelatin would have hopefully caught anything that was in that area, in the duodenum. Any of the larvae would have attached to it. So you pull it up slowly through the patient's mouth, and you can make a wet prep or a permanent stain with the material from that capsule. There's also serology tests and ELISA tests is available to test for antibodies to Strongyloides. And for the last slide on this recording, I have a good chart for you to help you remember how to distinguish hookworm rhabdidiform larva from Strongyloides rhabdidiform larva and hookworm falciform larva versus Strongyloides falciform larva.